Good evening, eminent doctors. I welcome you for this Dr. Reedys program of Peer Exchange Forum. We thank you for your efforts in providing good health to millions of cardiac patients in India. Dr. Reedys is now venturing into the new therapy of heart failure in India. We aspire to provide good health to every heart failure patient in India, which could be possible by partner with the eminent healthcare provider like you, who have given their support towards improving the patient survival. With the increased awareness, diagnosis, and treatment of heart failure, the therapy is certainly getting discussed at various national and international platforms and has been of a keen interest of cardiologists and physicians. Looking at the overall therapy complexity, there could be many unexplored area, unique cases, or debate issue which we feel can be brought to the table with eminent key opinion leader like you. Hence, we propose a joint discussion program, Heart Failure Peer Exchange Forum, which can bring about those unexplored, unique debate discussion out for the audience. We look forward for your association. So I welcome Dr. Basuraj Baligar sir as a moderator who will moderate the session for other doctors, and I welcome Dr. Vivekanand Gajpati sir, Dr. Amit Sattur sir, Dr. Prashant Kumar sir, and Dr. Narendra Hiragoda sir. He will join later to us on some time. So I will hand over the session to Dr. Basuraj Baligar to please continue.
Good evening, everyone. I welcome once again all my colleague intervention cardiologist, Dr. Gajpati sir, Amit Sattur, and Dr. Prashant. So straight away we'll discuss something about heart failure with preserved ejection fraction and regarding ARNI. I would like to start with Dr. Vivekananda Gajpati sir with some of the questions. Sir, what is your idea regarding the heart failure treatment according to the ejection fraction? Still, is it relevant?
Yeah, thank you, Dr. Basavaraj. Heart failure is diagnosed by signs and symptoms of heart failure like dyspnea, orthopnea, PND, pedal edema, or signs of right heart failure or left heart failure. And elevated markers also contribute to the diagnosis. We don't actually require echo to diagnose heart failure, but still it is relevant in our clinical practice. We want to ascertain that these symptoms are because of cardiac problem. So heart failure, according to European Society of Cardiology and ACC HA guidelines, they classified into three types: heart failure with reduced ejection fraction, that is ejection fraction less than 40%, and mid-range ejection fraction, that is between 40 to 50%, and preserved ejection fraction, that is ejection fraction more than 50%. To diagnose these varieties of heart failure, we require 2D echocardiography. But for treatment aspect, once the patient gets admitted with severe breathlessness and other signs of heart failure, we can start the treatment of heart failure without echocardiography. But for treatment to further classify, risk stratify these patients, we require echocardiography. Thank you.
Okay, the next question is to Dr. Amit Sattur. What is your idea regarding the management of heart failure with renal dysfunction patients and how to titrate these drugs?
Yeah, I think a patient of heart failure with renal dysfunction is one of the roadblocks of starting the heart failure foundation pillars. Beta blockers, the dose of which is not much affected in patients with heart failure, and it is proved beyond doubt that in patients of even CKD, even in patients of dialysis, beta blockers have been proved to be effective in patients to reduce the CV outcomes of CV death, MI, and stroke. And amongst beta blockers, it is bisoprolol and carvedilol, which have been extensively studied in patients of renal failure, even in patients of dialysis, and it proved to be effective. Second would be SGLT2 inhibitors. Now, SGLT2 inhibitors in various studies, be it heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, the eGFR at which these drugs were used, EMPA was used till the eGFR of 25, and DAPA was used till an EGFR of 30, below which SGLT2 inhibitors generally, according to guidelines, should not be used. But there were a lot of patients who were probably on dialysis or who were stage 5 CKD and were on SGLT2 inhibitors, which have shown to be of much benefit.
Regarding the
Titration is of difficult in cases of ARNIs and MRAs, wherein we are much worried of potassium levels. So ARNIs and MRAs, if the EGFR is less than 30 or 35, potassium of more than 4.5, we are very careful in initiating these drugs or up titration of these drugs.
In your practice, do you use the combination of hydralazine plus nitrates in the patients with heart failure and renal dysfunction?
This is probably the drug which we use or which was specified to be used in black Africans because of their low renin hypertension. They did not have a high renin hypertension. They had low renin hypertension. So this is how that came into existence. But in heart failure, the role of which is limited.
Okay, thank you. So this question is to Dr. Prashant Kumar. The managing of mitral regurgitation associated with or without heart failure and the role of ARNI.
Thank you, Dr. Basaraj. So basically, whenever we talk about managing mitral regurgitation, we talk about with or without being associated with heart failure. So here we want to discuss regarding the role of ARNI. So how does the ARNI act in such patients? Basically, what we are targeting is the vasodilators. So dilators, diuretics, and ARNI are the ones which are going to be having a significant role to play in such patients. And MR without heart failure, we don't have a significant data, but MR with heart failure with reduced ejection fraction. These are the specific population which was studied in the trials and found a significant improvement, which was almost statistically significant in patients who used ARNI and had a significant mortality as well as morbidity benefit. And that is where managing mitral regurgitation with heart failure with reduced ejection fraction becomes really easy with the role of ARNI to play in such a huge way. Thank you.
Okay. The next question to Gajapati sir. The cases of heart failure with reduced ejection fraction sequence of GDMT for the management. Why start with ARNI bar SGLT2 inhibitors?
Yeah, there are 4 pillars of heart failure treatment, especially in patients with the reduced ejection fraction. These are EC inhibitors or ARB or ARNI, SGLT2 inhibitors, beta blockers, and mineralocorticoid receptor antagonists. We need to start all these 4 drugs as soon as possible without any much side effects. And it doesn't matter whether we start ARNI first or SGLT2 inhibitor first or beta blocker first or spironolactone first. In my clinical practice, if the patient is stable, usually I start with ARNI and SGLT2 inhibitors. Next day, if the patient is stable, and during follow-up, I try to add beta blockers once there is no congestion. Even for hospitalized patients also, who are hospitalized with acute decompensated heart failure, first we give diuretics. Once the patient is properly decongested and if kidney functions are normal, then we can start these ARNI and SGLT2 inhibitors and sequentially add beta blockers and spironolactones. So it doesn't matter which we start first and second. Only thing is that all these 4 pillars of medical management has to be started and updated within 1 month of treatment. That will reduce the mortality and sudden cardiac deaths also.
So in some of the studies, they have started SGLT2 inhibitors in the second day of recovering from acute pulmonary edema and all. They think that the benefits are better with this SGLT2 inhibitors. What is your idea?
If the patient is very sick, acute decompensated heart failure, these patients are prone for acute kidney injury. And if you start SGLT2 inhibitor in such patients, they are prone for ketosis. And if you start ARNI in such patients, they may go into acute renal failure. So we need to wait for the stabilization. First, we need to stabilize the patients with the diuretics, decongest them, and we need to assess the renal function, urine output. If everything is okay, then we can start with the ARNI. And we can start, once the patient is stable, next day we can start SGLT2 inhibitors also. Beta blockers, if there is no congestion or pedal enema, we can start beta blockers. To start spironolactone, we need to rule out hyperkalemia, acute renal failure. So we need to take into consideration the side effects and contraindications of these drugs. If it is not there, we can start with the low dose and update it as early as possible.
Thank you, sir. So next question to Dr. Amit Sattur. Atrial fibrillation associated with heart failure. Shall we continue GDMT?
Now, atrial fibrillation is one of the important precipitors of decompensation in probably a chronic heart failure who's relatively stable. With the onset of atrial fibrillation, you lose atrial booster, there is a precipitous fall in the cardiac output, and the symptoms of heart failure is aggravated and they have acute decompensated heart failure. So presently, along with the GDMT, which includes ARNIs, SGLT2 inhibitors, MRAs, beta blockers, however, in trials, they have shown that the mortality benefit of beta blockers in patients of heart failure with reduced ejection fraction is less in patients who have atrial fibrillation than in patients who do not have atrial fibrillation. So beta blockers have reduced benefit in such individuals, but now catheter intervention for atrial fibrillation has become the choice for such patients because they have to remain in sinus rhythm, and it should be our ultimate goal of keeping them in sinus rhythm.
So they do this 3D mapping and ablation.
Exactly.
Do you still use digoxin in such patients, AF with heart failure?
It is presently digoxin is the one of the treatment of choice for rate control in heart failure with reduced ejection fraction. It is, I think, the use of digoxin is very, the indications are very less, and HFrEF patients with AF, I think it's one of the indications.
Okay, thank you. Next question to Dr. Prashant Kumar. The correlation between natriuretic peptides and left ventricular ejection fraction.
See, natriuretic peptides have got a significant role to play in heart failure, and we all know that there is an inverse correlation between natriuretic peptides and the ejection fraction as far as in heart failure and other things is concerned. So almost all the trials which had enrolled for whether it is ARNI or for SGLT2 inhibitors, they had one of the important criteria being natriuretic peptides. So what they found was there is a definite inverse correlation between natriuretic peptides and ejection fraction and the improvement in heart failure, and this was one of the important parameters which was studied along the trials, and that was an important parameter by which the symptomatic and without symptoms also, if there is an improvement heart failure, was clearly assessed using natriuretic peptides. Yeah.
Okay, thank you. So next question to Gajapati sir. Heart failure imaging, is it relevant to clinical management of patients?
Yeah, many of these patients, heart failure, we are managing based on reduced ejection fraction, mid-range ejection fraction, or preserved ejection fraction. But we need to identify the phenotypes of these patients. Many of these patients are having a treatable heart diseases. So with heart failure imaging, especially with cardiac MRI and nuclear scanning, we can identify patients with the cardiac amyloidosis, which will manifest as a restrictive cardiomyopathy, hypertrophic cardiomyopathy, where we can risk stratify patients regarding sudden cardiac death, and we can implant ICD to prevent sudden cardiac death. We can diagnose hemochromatosis, and several diseases can be diagnosed. Sarcoidosis. So many patients come with unexplained heart failure and heart blocks or ventricular arrhythmias. Many of these patients will be having sarcoidosis, so we can start steroids for them. And in patients with amyloidosis, there are two types: amyloid light chain type and ATTR type. For amyloid light chain, it is like a cancer. We have to treat it aggressively and identify it as early as possible. We can give immunosuppressive therapy like in multiple myeloma. But if it is a ATTR amyloidosis, treatment aspects are limited, and there are newer drugs available, although they are not easily available in India. But we have to diagnose all these conditions so we can prognosticate and as well as individualize the therapies.
Still, we can do coronary angiogram, sir, to
So,
note whether it's IHD.
I think for all heart failure patient, whether it is reduced ejection fraction or preserved ejection fraction, trying to rule out coronary artery disease is very important, because if the patient is having extensive coronary artery disease which is amenable for surgical therapy or angioplasty, it will definitely modify the trajectory of the patient.
Revascularization will help
Yeah.
for the patient. Okay. Next question to Dr. Amit Sattur. How is the management of heart failure with preserved ejection fraction different from reduced ejection fraction?
Yeah. We at this point of time know the phenotypic differences between HFrEF and HFpEF patients, the population who are at risk of HFpEF and HFrEF. The foundation pillars which Dr. Gajpati sir mentioned, SGLT2 inhibitors, ARNIs, beta blockers, and MRAs. In HFpEF patients, beta blockers have not shown to be of much benefit. In fact, there were few studies which have shown that use of beta blockers reducing the heart rate had unfavorable outcomes in HFpEF patients. So beta blockers are of questionable benefit and are not used according to guidelines. But the drug which has changed the management of HFpEF is SGLT2 inhibitors with the Emperor Preserved and the Deliver trial. SGLT2 inhibitors are class 1 indication for the use of HFpEF, and ARNIs also have failed to show any statistical benefit in HFpEF patients, though there are few trials which have been done and have shown a non-statistical improvement in these patients' hospital admissions, and have shown betterment of the diastolic profiles in echocardiography. Again, MRAs in HFpEF patients are class 2A indication.
I would like to welcome Hiregoda sir for this discussion. Sir.
To add to what Dr. Amit has said, HFpEF is a difficult subset to treat, and there are no ideal drugs. But then the recent guidelines, I think so, Amit sir has, I think so, one has to take care of the comorbidities associated.
Yeah.
What is an important cornerstone in treating HFpEF. And of course, as of now, only if patients are diabetic or non-diabetic, I think the SGLT2 has been shown to have some benefit in patients with preserved ejection fraction heart failure. That's what I wanted to add.
Sir, question to you, sir. Hiregoda sir. Sir, what are the diagnostic challenges in HFpEF patients? Your clinical experience.
Right. It all depends on what armamentarium you have in the diagnosis of HFpEF. Finally, it all lies down to a preserved ejection fraction. When a patient comes with acute pulmonary edema, of course, you do a bedside echo, and then you notice that he has a preserved ejection fraction, and then you have to see for other comorbidities like whether he has concentric LVH, then any diastolic dysfunction or relaxation abnormalities, whether he has diabetes. I think we have to take the total picture. And one thing that clinches is, of course, we have to do the markers like anti-ProPNP or anti-BNP markers. That is what clinches the diagnosis. Of course, it is HFpEF is like you have to take care of the cluster of diseases that the patient is associated with. So finally, you have a patient for you do an echo and you notice a normal ejection fraction, and then you do an diastolic dysfunction studies. Either you do a tissue Doppler imaging, then you do a biochemical study like NT-proBNP to see whether the enzymes are raised, and then you come to know that the most probably the breathlessness is because of a preserved ejection fraction heart failure. Thank you.
Thanks. So there is a scoring system for this HFpEF. The score of 1 indicates the HFpEF is unlikely. Score from 2 to 4 is you have to work out the patient in this thing coming days, and the score of 5 indicates it is likely to be HFpEF. Next question to Dr. Prashant Kumar. The role of ICD in a heart failure patient. What are the indications and the contraindications?
ICDs have been established in primary prevention and secondary prevention of sudden cardiac death in heart failure patients with reduced ejection fraction since the 1990s. But of late, regarding the recent advances like SGLT2 inhibitors, ARNI, we should reassess the indications for ICD, and we should really come to different cutoff for ejection fraction in such patients before we embark onto ICD therapy in such patients.
Thank you. This next question to Dr. Gajpati sir. Sir, out of so many drugs for HFpEF, which therapy clearly benefits HFpEF patients?
As Dr. Amit Satur said, many treatments are not recommended in or not useful in heart failure with preserved ejection fraction, although they are useful in heart failure with reduced ejection fraction, like beta blockers. These ARNIs have shown modest benefit in patients with heart failure preserved ejection fraction, especially when the ejection fraction is less than 55%, especially in females. But SGLT2 inhibitors have clearly shown beneficial effects in reducing mortality and repeated heart failure hospitalization in patients with heart failure with preserved ejection fraction. So as of now, only SGLT2 inhibitors are the approved the therapies in heart failure with preserved ejection fraction patients.
Thank you, sir. Next question to Hiregoda sir. Sir, should we start the Fantastic Four simultaneously as per the guidelines or sequentially?
Okay, the guidelines, the recent guidelines mention that you can start them sequentially. So it necessarily does not translate to what you should do in your day-to-day practice. Guidelines are there to guide you. Fine. Because the guidelines do not know what is the hemodynamic status of the patient other than the treating doctor. So whether you want to start it simultaneously or sequentially is dependent on the treating doctor there, depending on the hemodynamics. Finally, what is there is, anyway, to decongest, you are going to give him diuretics. Fine. About SGLT2 inhibitors, there is nothing. You can start it from day one. And then you can build up the beta blockers over weeks. You can start, and I think so it is a better option to build up the therapy. I can start it simultaneously, but build up should be over 2 weeks or 3 weeks, depending on the response, hemodynamic response of the patient. I leave it to the individual treating doctor who knows the comorbidities of the patient than to give a one size fits all sort of a therapy. Fine, I think so that should be the call. But then finally you have to see that all the 4 pillars of heart failure therapy, that is SGLT2, beta blockers, ARNIs and MRSA, are there on the patient depending on the tolerability within the couple of weeks that you have with him, depending on what is hemodynamic responses and how you assess the patients on his symptoms.
Thank you, sir. Next question to Dr. Amit Satur. How do you place the SGLT2 inhibitors in the treatment of HFpEF?
I think we have already answered this. I think that is the only class 1 indication medication in HFpEF which has shown benefit. All the other medications are class 2A and 2B. So this is the drug which has to be started across all spectrums of ejection fraction patients with heart failure.
Okay, thank you. Last question to Gajpati sir. Sir, recommendations on the use of ARNI for prevention of sudden cardiac death in these patients, in ARNI patients.
Yeah, ARNI, it has shown to reduce sudden cardiac death by about 20% in this one landmark paradigm HF trial. So, even if the patient is on AC inhibitors or ARBs, it makes sense to change it to ARNI because it will reduce the morbidity and mortality by another 20% and also reduce sudden cardiac death by 20%. Patient may be having class 2 symptoms or class 3 symptoms. Severe the class, lower the ejection fraction, more the mortality. But if you see the sudden cardiac death incidence in patients with heart failure, most of the sudden cardiac deaths occur in apparently asymptomatic patients. So it makes sense to use this ARNI even in patients with class 2 to class 4 patients of heart failure.
Okay, sir. Thank you. I thank everyone for participation and making this event successful. Thank you. Good night.
Thank you.
Thank you.